Today I'm going to present the mental state examination. So I'm going to give a brief summary of the patient. Like for example, today I'm going to present the MSc of a 25-year-old John who has presented with he has presented after a recent breakup with his girlfriend. Okay, so I'm going to follow the mnemonic AB septic J triple R. So in which A is for appearance. I'm going to look at the appearance of the patient, look for distinguishing features, the weight of the patient, any stigmata of disease like jaundice, look at the personal hygiene of the patient, look at clothing, whether they are appropriate to the weather, and look if the patient has brought any objects with them. Then I'm going to look at the behavior of the patient. In the behavior, I'm going to look at engagement and rapport, whether I'm able to develop a rapport with the patient or whether they appear distracted or engaging with any hallucinations. Look at the eye contact of the patient, if it's reduced or excessive, the facial expression of the patient, if the patient is looking relaxed, angry or disengaged. I'm going to look at the body language, if it appears threatening or withdrawn. Then I'm going to look at the psychomotor activity, if there's any retardation, if there's paucity of movements and delayed responses to question, or if there's restlessness, and abnormal movements or postures, so involuntary movements, tremors, tics, lip smacking, akathisias, rocking. So all this comes under behavior. So engagement and rapport, eye contact, facial expression, body language, psychomotor activity, and abnormal movements or postures. After appearance and behavior, next speech. So I'm going to assess the patient's speech looking at rate, quantity, tone, volume, fluency, and rhythm. So in the rate, I'm going to see if there is pressure of speech, tendency to speak rapidly, and that is usually seen in mania, and flight of ideas will also be there. So this is pressure of sleepy speech, or if there's slow speech with major depression. Then quantity of speech, it can be minimal or absent with depression, or it can be excessive speech with mania and schizophrenia. Then tone of speech, it can be monotonous speech in depression, schizophrenia, and autism. It can be a tremulous speech associated with anxiety. Then the volume of the speech, I'm going to notice if it is loud or if it's soft. Then the fluency and rhythm of the speech, for stammering and stuttering, whether it's present, or it's a slurred speech in major depression due to psychomotor retardation. So after speech, I'm going to look at abceptic, so E for emotion. And under emotion, we have mood and affect. So mood is what the patient has described to you, and affect is what you observe. Okay, so in mood, it's how, when you ask the patient how are they feeling, what is your current mood, and they are going to say whether they are having a low mood, or they are anxious or angry or enraged or euphoric or guilty or apathetic. Okay, affect is when you observe the patient could be angry, sad, hostile, or euphoric. Okay, apart from the apparent affect, you're going to look at the range and mobility of affect, whether it's fixed, restricted, or labile throughout the interview. If it is restricted, the affect changes slightly in the interview, but it doesn't demonstrate a normal range of emotional expression. In labile affect, patient will have no control over the emotions, and it is exaggerated changes happen. So patient can be very sad and very happy during the consultation. Intensity of affect, whether it is heightened like mania and some personality disorders, or it is blunted or flat like depression, schizophrenia, or PTSD. Then congruency of affect, whether it is in keeping with their mood, with the affect and mood are congruent with each other. So in emotions, we look at mood and affect. In affect, we look at whether the range and mobility, intensity, and congruency of affect. Then after abceptic, okay, so after emotion we go to perception. So in perception, we do whether the patient has any hallucinations. So hallucinations could be auditory, visual, and tactile. Okay, and it could be pseudo hallucinations, the patient is aware that it is not real, or it could be illusions, misinterpretation of an external stimulus, thinking a shadow is a person or a rope is a snake. And even depersonalization and derealization comes here. Depersonalization, patient feels they are no longer themselves, they are someone else. Derealization, they feel the world around them is not a true reality. Okay, then after perception, we come on to thought. In thought, we have three things: thought form, thought content, and thought possession. In thought form, we have the processing and organization of thoughts. Okay, so that is speed of thoughts, if it's very fast, and it's slow thought processing, or it's slow thought processing. Then flow and coherence of thoughts. In this, we have loose association of thoughts, rapidly moving from one topic to another without any connection between the topics. Circumstantial thoughts, the thoughts are irrelevant and unnecessary details. Tangentiality of thoughts, they digress from the main subject and they don't come back to it. Unrelated, oblique and irrelevant thoughts. Then flight of ideas, in this they have pressure of speech and they have increased rate of delivery, and language has a wealth of associations, and there are accidental connections can happen, and there's excited speech that wanders off the point. Okay, then you can have thought blocking, which is sudden cessation of thought typically in mid-sentence, and you have perseveration, in which they keep on repeat a particular response or phrase or word or gesture, and they have neologisms, which is new words that the patient has made up. So this all comes under the thought form. It can be linear, which is normal thought form. So circumstantiality, tangentiality, flight of ideas, thought block, perseveration, neologisms, and loose associations. Then coming over to thought content. In thought content, all the delusions come here. Firm fixed belief. Okay, so delusions of RCGGP. So that is reference, control, grandiosity, guilt, persecution, and paranoia. These are all the delusions which can come here. Obsessions and compulsions also come here, and overvalued ideas come here, along with suicide and homicidal thoughts. All these come under thought content. Then we come out to thought possession. That includes three things: thought insertion, thought withdrawal, and thought broadcasting. Okay, then abseptic. After thought is insight and judgment. Insight, whether, what do you think the cause of the problem is? Do you think you have a problem and do you feel you need help? Whether the patient has insight. Then cognition can be formally assessed using the mini mental state examination, but just informally, whether you think the patient is oriented to time, place, and person. Also, there could be things like attention span, concentration levels, and short-term memory, but main thing is orientation in cognition. Okay, then coming on to judgment. What would you do if you could smell smoke in your house, or if there's a fire in the room? So what this refers to impairment in decision making. Okay, and then you end with 3 R's: risk, reliability, and rapport. So for the risk, if the patient is depressed, we use the sad person score. If the patient is having hallucinations, the patient will be put under risk. Then your rapport, which you talked a bit about in the behavior, you're going to confirm it in the end with your rapport with the patient. And then reliability. Do you think this patient's history is reliable? If it is not reliable, you would like to correlate with someone who is the support person of the patient. So that was the end. If you can give a small diagnosis at the end of it, you can. Otherwise, this was the end of the mental state examination.